Hello, welcome to this edition of Health First. Today we will hear from Dr. Benjamin Rogers with Coleman Internal Medicine as he discusses more about osteoporosis prevention and tips. Stay tuned.
We're here to, as you know, if you've seen this and you probably knew already, that we're here to talk about osteoporosis today. And this is a topic that's very important, not just to us as internal medicine physicians, but also to you as patients. If you don't have osteoporosis, you've most likely been tested for it or know patients with it. We've all had family members that have been affected by this very prevalent disease. One of the things I want to emphasize is the impact of osteoporosis on people's lives and on our healthcare system as a whole, but then also the fact that it's a preventable disease. So osteoporosis is not only preventable, we can detect it before it causes problems, and of course the most dreaded complication of osteoporosis is bone fractures. And so we want to diagnose it before somebody has a fracture so that we can hopefully prevent it. And then even if someone has a first fracture, we can decrease the risk of having a second broken bone if we treat them appropriately. So of course we need to define what osteoporosis is. And osteoporosis is a skeletal disorder, so it's a disorder of your bones. And it's comprised primarily of poor bone strength. And bone strength is really made up of two things: the amount of bone that there is, and then the quality of the bone. So how dense is the bone, and how good is the quality. And so if someone has poor bone strength, as you can imagine, it puts them at increased risk for having bone fractures. And when we talk about fractures and osteoporosis, we're talking about any fractures. So any bone in your body that can be broken is more likely to be broken if you have osteoporosis, but we primarily are concerned about fractures of the wrist, of the hip, and of the spine, because those are the most common and those have the greatest impact on a patient's function. So this probably doesn't show up really well, but you have here a picture. Let me show you if I can with this slide here. So here in the middle, this is a picture of a normal bone, and it's taken from this patient's hip right here. The neck, the femoral neck of their hip. This is normal, healthy bone. Bone is not solid. It's porous. It's like it's a porous structure. But as you can see, perhaps, and if you can't see here, you can look at the bone models over here later. Even a healthy bone has some empty space in there. So it's almost like a network. If you think about a building that has struts and cross beams, that's what your bones have. It's this interlacing when it's healthy, is extremely strong. It can take an incredible amount of force, a loading force, because of the way it's designed. But in osteoporosis, the bone looks more like this on the right, over here, where you can see there are much larger empty spaces compared to here. And even the struts that remain are much, much thinner than in the healthy bone. So obviously you can just tell looking at this. I mean, this is like an electron microscope from a biopsy of a bone, and you can say, it's obvious that structure on the right just would not be, it looks like a honeycomb or something. There's no way it could withstand structure, it could hold our body up. So I wanted to talk a little bit about the impact of osteoporosis on our country. All of us, as I mentioned earlier, know people who have osteoporosis. Some of you probably have it yourselves. It's a major health threat for about 50 million Americans right now. And it's estimated that this is going to become more and more prominent as the baby boomers age, as we live longer. It's just going to have more of an impact on our health. So it's estimated right now that about 9 million women and 3 million men in this country have osteoporosis. And if you include patients who have osteopenia, which is sort of a pre-osteoporosis condition. So you got normal bone, it starts to get a little weaker, that's osteopenia, and then it gets real weak, it's osteoporosis. So if you include people who have low bone mass, they don't have osteoporosis yet, but they have osteopenia, there's about 40 million more of those. So all told, we're talking about 50-something million Americans that are affected by this. And let me throw a couple of statistics out there just in case this isn't enough to tell you that this is an important disease. 1 in 2 women over the age of 50, so a lot of us are over the age of 50, so 1 in 2 of you, 50% of you, will have a broken bone because of osteoporosis. 1 in 4 men over the age of 50 will have a fracture at some point in their life related to osteoporosis. And these fractures are extremely devastating, as we'll talk about in a few minutes. And another point that's surprised me, or it may surprise some of you, it doesn't really surprise me based on what we see in the hospital, but the most common cause for someone having to go to a nursing home is a hip fracture because of osteoporosis. So we admit patients to the nursing home from the hospital pretty frequently. The most common reason is because of osteoporosis causing a bone fracture. So I mentioned, so that's just something to keep in mind. I mean, if your goal is to stay out of the nursing home or as long as possible and live as active a life as possible, then this is something that we want to try to avoid. So here's a slide about the most dreaded complications of osteoporosis, and that's bone fractures. So the data here is a little old, but in 2005 there were more than 2 million broken bones as a result of osteoporosis. So we're not talking, all broken bones obviously aren't from osteoporosis. Somebody has a car wreck and they break a bone or they fall off of a roof or whatever. That doesn't mean you have osteoporosis. But if you have a fracture, so if you break your hip or your wrist or your spine from something that's non-traumatic, so it's not a trauma. Let's say you bump into something and you break your back. Let's say you fall, you trip and fall, and you break a hip. Those are non-traumatic. And so by definition, those people have osteoporosis. You don't have to do any fancy testing. You know if they're over 50 and they have a broken bone that's just from something small, and it doesn't really matter what any tests show, you know they have osteoporosis. And so there was 2 million cases like that in 2005. As I said, the most of those were hip fractures, back fractures or vertebral fractures, and wrist fractures. And then there are some pelvic fractures and then a bunch of random sites. So to quantify it a little bit in financial terms, we think that by the year 2015, this disease will cost our healthcare system $25 billion a year. And then you think about 2025, I said 2015, I meant 2025. So you think about it, that's only 10 years from now. So 2025 still, it looks like a number way out in the future, but that's about 10 or 11 years from now. This is going to be costing us $25 billion. Another 15 years after that, they think that'll double to $50 billion a year. Okay. So, and that cost comes from obviously the doctor's visits, treatment with different drugs, nursing home admissions, being in the hospital, and a bunch of other things. And that doesn't even account for the quality of life that people lose. All right, so because this slide was initially prepared for physicians, it has some data about how well we're doing as a healthcare system treating osteoporosis. But when I saw this, I thought this is worth all of us knowing. You in attendance here are obviously concerned about the health care, not just of yourself and your family, but of our community as a whole. And so I think that we, as citizens of Cullman, and as people who have a stake in this hospital, there's some things that we should be aware of. And this was prepared in 2004, so it's about 10 years old, but it was prepared by the Surgeon General, and they wanted to see, the Surgeon General's office wanted to see, how well are we doing about osteoporosis, specifically hip fractures. There's so many hip fractures, they're costing us so much money. How well are we doing to prevent those and to treat them? And it's just devastating. It's just damning evidence for us as physicians, as a healthcare system. So they looked at one system, this I think it was in the Midwest, they looked at this hospital system that had 4 large hospital systems. So when I say a hospital system, I don't mean just a single hospital, but you think of something like, not Cullman, but in Baptist Hospital or something that has many, many hospitals associated with it. They looked at 4 hospital systems, and they found that of people who were admitted to the hospital with a hip fracture, only 1/4, so 25% or less. Some hospitals it was worse than that. Some of them it was 12%. But 12 to 25% of people who had suffered a hip fracture were ever tested for osteoporosis. So you have all these people with hip fractures, and only 1/4 of them are even being tested for osteoporosis. Of all those people that had a hip fracture, guess how many were told they need to take more calcium and vitamin D? 25%. So I mean, you are better educated than that. You're here at this function, so probably all of you could have told me before we started, like, what do you need to do for bone health? You probably all would have said things like vitamin D and calcium. But as a healthcare system, we're not doing a very good job telling our patients that, even after they have a hip fracture. So we know they have osteoporosis, and they're at very high risk of having another one. Furthermore, only 1/10, so 1/10 of patients who were treated for a hip fracture were put on medicines to treat their osteoporosis. So 1 out of 10 patients who have a hip fracture, now they go into the hospital, they get their surgery, they get pins or whatever they needed to fix the hip. They get shipped off to the nursing home for rehab, but only 1 out of 10 of those patients will have their osteoporosis treated. So I hope that sort of tells me I need to do a better job, and all of us as patients and as patient advocates need to make sure that our loved ones, if they've had a fracture, are being treated. And if you have questions about this disease, you need to talk to your physician. Okay, so osteoporosis, as I said, is a preventable condition. And so what are some of the risk factors that put certain people at higher risk than others? I mean, we could test everybody, right? But that's even more costly. And not everybody has risk for osteoporosis. So typically beginning about the age of 50 in men and beginning at menopause in women, and the average age of menopause is 51. So in general, we say about at the age of 50, we should start looking at our patients and thinking, what is their risk of having osteoporosis and having a hip fracture? Some people are going to have no risk, and so you don't test them. But we believe that all women at the age of 65 need to be tested if they haven't tested previously. So if you're 50 to 65, if you have some risk factors, you need to be tested. If you're 65, regardless of your risk factors, you need to be tested. If you're a man, the recommendation is that you be tested at the age of 70. And even before that if you have risk factors. So what are some of these risk factors? Well, here's a long list of them, and we'll go through there in a minute, but the first one really I think is important. So your low bone density, well you say, well that's what is osteoporosis, is low bone density. But let me speak specifically to women here for a minute. So you have menopause about the age of 50. In the first 5 years after menopause, you'll lose at least 10% of your bone strength. It keeps going down after that, but not as rapidly. So those first 5 to 10 years, you lose a great percentage of your bone strength. So if you start off with stronger bones, then you're less likely to ever have osteoporosis. If you already have kind of just average bones, then you lose a little bit and you're going to more likely to get osteoporosis. But if you start off with really strong bones, and you lose 10%, maybe you're still going to be good. So that's something for us to emphasize to our younger patients and our younger females in the family, is that by diet, the right diet and exercise, if they can really strengthen their bones when they're younger, before menopause, they can lower the risk of ever having osteoporosis in the future. Advancing age is what we call an independent risk factor, meaning just getting older increases your risk of osteoporosis, even if you don't have none of these other things. If you've had a hip fracture before, or any kind of fracture, that increases your risk of having osteoporosis, because we know something in the structure of those people's bones makes them have poor bone quality, and so they're more likely to have osteoporosis. If you have a parent who has had a hip fracture, you're more likely to have osteoporosis. Certain medications increase your risk of having osteoporosis. There are many, many, many drugs that increase your risk of osteoporosis. One of them is proton pump inhibitors, for acid reflux. So omeprazole, Nexium, Prilosec, all of those increase your risk of osteoporosis. Now it's a very, very small increase, so that's not a major player. So if you have good reason to be on those medicines, don't stop them just for this. But the biggest medicine is steroids, prednisone, and then we're not talking about taking prednisone, for 5 or 7 days for a COPD flare-up. We're talking about people that are on steroids for like 3 months or more at a time. Then that really increases your risk of having osteoporosis. And again, some people have to be on those medicines to prevent other bad diseases. So you just have to weigh the risk and the benefits, the pros and the cons. Caucasians and people of Asian descent are more likely to have osteoporosis. Women and men who have a small frame. And so we're preaching to people all the time about maintaining a healthy weight, but actually, this is one case where being thin is not good. So you have to do other things. So if you have a natural small frame, you may even want to be more concerned about strengthening those bones. Because if you can think about it, if you're a bigger frame, then I don't necessarily mean obese, I just mean if you have a bigger frame, bigger bone structure, that puts more stress on the bones. And so they're going to be stronger. Bones strengthened by stress. So you're stressing those bones, and so they get strong to hold up your body all those years. So low estrogen in women increases the risk of osteoporosis, and that's why after menopause, women start getting osteoporosis. Women are protected from certain things because of estrogen. You have lower heart disease because of estrogen, but then when you lose your estrogen at menopause, then you start having more osteoporosis. Women that go longer periods of time without estrogen are more at risk. So if you have a hysterectomy where they remove, total hysterectomy, or you have early menopause, that puts you at higher risk. And so that's one reason some OBGYNs will put, if they have to do a hysterectomy for some reason on a woman in her 20s, they're probably going to put that woman on hormones, at least until she's 50 or 60, so that she can protect her bones the same way that someone naturally would if they hadn't had that hysterectomy. And then low testosterone in men can predispose to osteoporosis. So all these things, there's not many of these that you can change. We can't change your age, we can't change your family's history, we can't change your race. We can increase your bone strength a little bit, but here are the things that we know you can do. So if you have a low calcium in your diet, if you have low vitamin D in your diet, those both predispose you to having osteoporosis. High salt, so high sodium diets, increase your risk of osteoporosis. Drinking lots of caffeine does that. Immobilization, so if you're not active, that increases the risk because again, those bones aren't being used and so they just weaken. If you're not using them, you're gonna lose them. If you drink 3 alcohol drinks a day or more on average, then that puts you at higher risk of osteoporosis. Not getting enough physical activity, again, leads to poor bone strength and makes it more likely to have osteoporosis. And then smoking, whether you're smoking or people around you are smoking, may also increase your risk for osteoporosis. You can get a fracture, you can get a broken bone from just about anything if you have osteoporosis. You can bend over to pick up a pencil and break, have a vertebral spine fracture. You can bump into something. But the most common cause of osteoporosis-related fracture is from falling. So there are things that we know predispose people to fractures because it predisposes them to having a fall. So if you have osteoporosis and you're falling a lot, then you're more likely to have a fracture. And so what are some of the things that predispose people to falling? Well, some of them are obvious. If you fall in one time, you're more likely to fall a second time. And so occasionally your doctor may ask you, have you fallen in the last 12 months? And so I ask my patients that sometimes, and I think they think it's kind of funny or they don't know, I walked in here, but you want to know, are you falling frequently? Because that's kind of a clue, what's going on? Because that could mean they have poor eyesight or maybe poor balance, or maybe a bad gait, or maybe dementia, or maybe poor hearing. Because all those things can predispose them to falling, which then dramatically increase the risk of having a fracture. There are things you can do around the house if you know somebody has osteoporosis, or even if they don't, and that is make sure you have adequate lighting, make sure there's not obstacles laying around, extension cords, lighting cords that they can trip on, loose rugs that they can trip on. And then, of course, the things that we think about in the bathroom, like assistive devices on the wall or near the shower or toilet to give people assistance if they need it. And then, of course, slippery outdoor conditions. So if there's ice or rain, then you're more likely to fall. Now we talked about some of this: poor vision, weakness, frailty, medications that cause oversedation. So there's been a big push in our patients that are over 65 to limit the medicines that we give you that can make you a little sedated. And so some of you have encountered that with your insurance companies. Your doctor has written you a medicine, and your insurance company either sends you something or sends your doctor something saying, do you really want to give this to this patient? You know, they're over 65, and this does make them have higher risk of falling. So there are certain medicines that we used to use just through somebody's whole life, and now we're starting to say, you know, after 65, we need to be careful with certain medicines because they make people a little sedated and more likely to fall. So, you know, this is sort of a pictorial example or a graphic example of what osteoporosis can do for you. This poor lady has had multiple compression fractures in her spine. I have patients that look like this, and you really hurt for them, you know, because it just looks like it's painful, but often they're just really sweet, pleasant women, and they're not necessarily in pain. And they may have just thought in their generation that this is natural. My grandmother had kyphosis. So kyphosis is, you know, being hunched over. My grandmother had it, my mother had it, I'm going to have it. And they don't understand maybe that the reason they're hunched over is because the backbone is breaking. And what this is also showing is that once you've had a vertebral fracture, you're more likely to have another one. So you think about it, your spine is made up of vertebrae, which are building blocks like this, and there are discs between them, but you got these discs. Well, if one of those breaks, and the way they often break is they compress, so they kind of collapse a little bit. Well, so if this one down here collapses a little bit, it's tilted, well, that changes the angle and changes the stress load, and so then the one above it later is going to tend to slip down. And so you see this just progression of the kyphosis. And so once you have one, it's very likely that you're going to have another one. And so some of the keys that someone may have had a back fracture or back pain. Now, that's usually only in the first few weeks after it happens, so you're going to have pain. And that's critically important time, because if you have a fracture then, sometimes there's things we can do to fix it. But if they're starting to get slumped over, if they're having back pain, sometimes it can even cause symptoms. So this lady, you know, she's slumped over. Sometimes that'll compress people's abdomen, you know, your content, your organs. It kind of squishes them together. So she may have indigestion or heartburn because of that. Or she may have trouble breathing. Sometimes people will get COPD just because their lungs are now scrunched together. All right, so again, wanted to talk about hip fractures. Some of this I've said already, but hip fractures are the most feared complication of osteoporosis. And why is that? Well, it just has a tremendous impact on people's mobility. If you break a wrist, you know, you can kind of deal with that. But if you break a hip, I mean, that really limits your ability to get around. People who've broken a hip in the next year have a 10 to 25% excessive risk of dying versus someone who didn't have that hip fracture. 30% of patients who have a hip fracture will be in a nursing home long term. So somebody has a hip fracture and comes to the hospital, the orthopedic surgeons will fix them, and those patients almost always go to a nursing home for 21 days, we've all heard of that, and to get rehab. But 30% of those people will never go home. Again, remember I said that hip fractures are the most common cause for going to a nursing home. Some of these, it's just really almost a little depressing. 6 months after having a hip fracture, only 15% of patients are able to walk across a room without using a cane or a walker. So 15% of patients 6 months later can walk across the room by themselves. So that's really had a dramatic toll on their quality of life. And then fewer than 20% of patients that are in the hospital because of a hip fracture ever get to where their same level of activity that they had before the hip fracture. Okay, so how are we going to diagnose osteoporosis? Well, I've mentioned to you one way already. If you have a fracture, if you have a bone fracture that's not related to trauma, then you have osteoporosis. by definition. So again, that's a non-traumatic fracture. I mean, you could be 70 and be, riding a horse and get thrown off or fall off a ladder or whatever, and you break something. That doesn't necessarily mean you have osteoporosis. You may, but it doesn't necessarily mean it. But if you just fall from standing and break something, then you have osteoporosis, regardless of what any test says. But we do have a test that helps us figure out what that is. And probably all of you have heard of a DEXA. I usually spell it D-E-X-A. They spell it D-X-A. We pronounce it DEXA, and it stands for Dual Energy X-ray Absorptiometry. And it's just a way of measuring how dense your bone is. It's a measurement of both of your hips and your back. Now, there are other ways you can do this, and at community health fair and school events and work activities, some of you have been tested, and what they'll do is they'll just use an ultrasound or an x-ray to test the bone strength in a finger or a foot or an ankle, a heel, or a forearm. And those tests are okay, but they don't correlate perfectly with the bone density scan. In other words, last week or this week, or several weeks ago, I saw a patient who, and it was a man, I believe, who had one of those community screening tests, and it said, hey, you have poor bones, you may have osteoporosis. So he came to see me, and we got the real test, the DEXA scan, and I saw him back this week, and he doesn't have osteoporosis. And that's okay. You want a test that you're doing out in the community for screening, you want it to be oversensitive, because you don't want it to miss anything. You'd hate for it to say you're fine and then him never get tested, right? You'd rather it say you've got poor bones, go see your doctor. And so at least that way they're not going to miss people. But the gold standard, the best test, is a DEXA scan. So just because you've had one of these scans, on your finger or your foot, at the Civic Center or something, if it says you're okay, you still need to talk to your doctor about getting a DEXA scan. So I guess that's all I was really going to say there. And I've mentioned who should be tested. So women starting at 65 and men at age 70 should be tested. Sometimes it's a hassle trying to get insurance companies to pay for men to be tested, but they'll pay for every woman because your risk is much higher. They'll pay for every woman at 65 to get tested. And younger women need to be tested if they have certain hip fractures. So in practice, a lot of times we just test every woman sometime after she goes through menopause. But certainly at 65, but a lot of women need to be tested before that. Then what can we do to prevent it? So this, again, is a slide talking to doctors, but so you just got a little insight on what we're supposed to be telling patients. So we're supposed to be telling patients all those risks that we went over: risk of falling, smoking, drinking too much alcohol, not exercising, drinking too much soda. All those things increase your risk of osteoporosis. Not eating enough calcium or vitamin D increases your risk. And then obviously falling and poor balance increase it. So we talk about a calcium-rich diet, and that's typically things that have whole grains, milk products, cheese, and fruits and vegetables. And then you can also supplement that sometimes if you don't think you're getting enough with medication, for over-the-counter tablets, calcium tablets. There are ways that you can estimate how much calcium you're getting in your diet. And the best way to do that is some online calculators where they can tell you how much calcium is in each type of food. But some of these resources may have some of that information as well. So you want to limit soda consumption. That's Diet Coke and regular Coke. Those two things have a lot of bad effects on your health, but they also adversely affect your bones. High potassium foods help your bones, but high sodium foods, high salt, hurt your bones. So you want more potassium, less sodium. Younger women need to make sure they're taking enough iron and folate, and then people over the age of 50 want to be thinking about B12. If you have a low B12 level, you want to work on getting that up. And then also vitamin D for certain patients. That's been a big push in the last 10 years, is increasing people's vitamin D intake. And of course, you're more likely to have low vitamin D if you're dark-skinned or you're staying inside a lot. And why is that? That's because sunlight stimulates your skin to make vitamin D. So if you have darker skin, then your body is not going to absorb as much as the sunlight. And then, of course, if you're staying inside, and we've always been told for years by the dermatologists, stay out of the sun to prevent skin cancer, but now we're all getting low vitamin D. So you got to balance, so it's a balancing act, So typically, we're not talking about a lot of sun exposure. We think that about 15 minutes of sun on your skin, not just being out there with a big hat and long sleeves, but 15 minutes of sunlight a day probably will give you enough vitamin D. And it doesn't have to be in the hottest part of the day, which is the worst time to get the sun for your skin cancer. So a good diet that we just talked about helps strengthen your bones, it helps slow down the loss of bones, and it just makes you healthy overall. All right, so there is a role of exercise in preventing and treating osteoporosis. So exercise does a number of things. Exercise may actually stimulate your bones to be a little bit stronger, but it has a number of other effects. It decreases your risk of falling. The better your balance, the better your gait, the better your strength, the lower your risk of falling. You're going to have just better muscle tone, better posture, better flexibility, and exercise improves your mood. A lot of times I recommend exercise for even patients who are depressed or who have low vitamin D or have fibromyalgia. It just releases these endorphins, which are your body's natural opioids in your brain, and it just makes you feel better. So the kinds of exercise we're talking about here are weight-bearing exercises and muscle strengthening exercises. So muscle strengthening exercises are probably pretty self-explanatory. That's things like weights and resistive activities. So it doesn't have to be weights, it can be bands. Even swimming in a way is a resistive activity because you're moving against the water. But weight-bearing activities are exercises or activities where you're moving against gravity. So your legs and feet are moving against gravity. So that includes walking, it includes dancing, it includes, obviously more strenuous things like tennis, it includes bicycle riding. So anything where you're having to work against gravity. Which incidentally is why astronauts get low bone mass, and that's one of the things they have to be careful if you spend much time in space, which probably isn't a risk for most of us. But they get low bone mass. They get low because they can move and there's no resistance, and so their bones just weaken and waste away. So again, some of the things I may not have mentioned: stair climbing. Yoga is not really a weight-bearing activity, and it's not a muscle strengthening activity, but yoga helps with balance and gait. You do want to avoid certain types of exercise. You don't, if we're trying to avoid hip fractures and back fractures. If you're an elderly person or you have osteoporosis, you don't want to be doing things that have real strenuous twisting of your spine or bending of your spine at your waist. So some of that stuff's obvious. You don't want to just be doing really aggressive sit-ups or crunches because you're just bending your back and you're going to predispose yourself to having a fracture. You want to be careful, especially activities where you bend forward and twist your spine at the same time. So a lot of times, if you want to bend over to pick something up, you kind of bend forward and twist over there to get it. Well, that's putting stress on your spine in two different directions. Even sometimes the way we cough, you bend over and you turn your head if you have a violent cough. So sometimes people will have a back fracture from coughing. So I mentioned earlier about the role of proper alignment. That woman who was getting kyphotic or bent over a little bit or hunchback, she had a compression fraction, and so that changes the alignment. Well, God's made our spines it's a neat way it's curved. I didn't bring a picture, but your spine's curved, and that's designed to withstand the weight of your body. Well, if you're not having good posture, then that changes the angle and puts stress on bones in a way that they doesn't use their maximum efficiency, and so it predisposes you to having a fracture. I'm not going to talk much about the treatment of osteoporosis. I'm just going to briefly mention a few of the classes of medicines, and any of you who are on medicines will find your class of medicine on these slides, but I wasn't going to deal a lot with individual medicines. So here are the different classes. there's what we call anti-resorptives and anabolic medications. And so to help you understand this, your body is constantly being remodeled. Your body has cells called osteoclast, which are constantly chewing up your bone, and then you have something called osteoblast, which are making new bone. And so, because you don't want to just have the same bone all your life, and so these cells are chewing them up, and more cells are putting it down. What happens in osteoporosis is you're chewing it up faster than you're putting it down. So there are some medicines that stop those cells from chewing it up so fast, and those are probably the ones we're most familiar with. Bisphosphonates. A lot of you have heard those. Boniva, Actonel, Fosamax. Those are the bisphosphonates. They slow down the chewing up of the bone, so to try to keep that balanced. But you also have calcitonin, which can come in a nasal spray, and you have estrogen medications, or estrogen-based medications, or hormones. And we have to balance using hormones in the elderly with other things. It's good for the bones, but it increases your risk for some other things. And so, those can be used for osteoporosis. And then there's a couple of newer types of medicines that actually stimulate your body to make more bone. So it stimulates those cells to build bone faster. And one of those is called teriparatide. The brand name is Forteo, and it's a shot you to give yourself in your belly every day for 2 years. And it's the strongest treatment we have. So people who have really, really severe bones, or they've had multiple fractures, get this. And I have a few patients on it, and it's remarkable what it does for their bones. And so there's a model over here that shows you, this is from a real life person where they took a biopsy of a bone and then they blew it up and they made this model, and the bone looks terrible. In fact, if you're not careful, you'll break it, this model, if you touch it. And in fact, if you drop it, it'll shatter. And then after 2 years of this Forteo, then they took another biopsy of the bone and just looks so much better. And then there's a new medicine that's a whole new class that's called Prolia. And there's a sample of what their medicine does to bone as well. So bisphosphonates, just in general, just if any of you are on Boniva, Fosamax, Actonel, make sure you're taking it with a full glass of water, preferably first thing in the morning, and make sure you don't lay down for, some of them say 30 minutes, some of them say 2 hours, because you don't want that pill to get stuck in your esophagus because it can cause some problems. So drink it with plenty of water and stay up for a little while. And we ideally say take it in the morning so you're up all day, and just make sure that gets into your stomach. Well, there's somebody in my family who has osteoporosis, a relative of mine, who has told me that she's not real sure she's always compliant with her medicine. And it is tough to remember to take these medicines, partly because they're not on a regular schedule. Most of those bisphosphonates, you don't take every day. You take once a week, or once every month, or once every 6 months, or something crazy. Well, who can remember that? You know, at least it's more inconvenient to take it every day, but at least you know to take it. And so that's what studies have shown. Only 20% of people that we put on medicine for their bones take it consistently for 24 months, for 2 years. But we know that people who take it regularly have lower rates of bone fractures. So that's really all that I prepared today. I wanted to refer you to this organization. It's called the National Osteoporosis Foundation. They have an amazing website, both for physicians and for patients. Just amazing amount of material that's very, very helpful. So if you have any questions on osteoporosis, I would encourage you to go to the National Osteoporosis Foundation. It's just nof.org, or you can, of course, call them. I don't have their number here, but they'll be happy to send you a lot of information and answer any questions that you have. I think that's all that I had, but I wanted to see if anybody had any questions.
We hope you enjoyed this episode of Health First. If you would like more information on this episode or any of our other episodes of Health First, please feel free to contact us at 256-737-2600 or on our website at cmchospital.com.